Hi, everyone, and welcome to this module in MHA621 on the cost of healthcare. There's some excellent content pieces to go along with this YouTube video, and I'm going to be describing all of them within this lecture. And so why don't we get started? And so really at the end of this entire module, what I'm hoping is you're going to be able to, in the spirit of MHA 621, have a generalized and specialized focused on the cost of healthcare from a user perspective, and also be able to summarize some of the issues rising from different payers in healthcare, how some services are charged, and overall how health payment systems function. It's a pretty tall order for the week, but let's get started by looking at the big picture national healthcare expenditures. And this actually comes from it's Exhibit 3 from the Health Affairs article in your reading. And I want to highlight this exhibit here because it tells an interesting story starting from 2004. They've really clumped it up into different years, but 2004 going all the way up to 2019, and really summarizing essentially the three primary factors that account for the growth in per capita national healthcare expenditures, so per individual, but from a national perspective. Residual use and intensity, so how much use there is and the intensity of that use from healthcare services, the price of medical care, that's all medical care, and the age and time of death. Now, this is, I think this last piece, which you can tell is fairly consistent over the time frame, matters because as individuals age, they, for the most part, tend to consume more healthcare services. And studies have indicated for the last 25 years and the last 6 months, certainly in the last year of life, particularly for individuals, older adults, they're consuming the vast majority of healthcare services that we expend in the country, but it's fairly consistent. What isn't consistent are the other factors. And as we look at medical prices, you can see from 2004 how much it's fluctuated. Now, part of that is in this time frame, in 2010, the Affordable Care Act was enacted, and that's been enacted over since that time period up until today. You can certainly see a drop in medical prices, but an increase and then a drop again, really a fluctuation. Most of those medical prices are associated with two primary services that are offered: any type of technological functions and pharmaceuticals. And those two also complement each other. You can also see the residual use and intensity before the enactment of the Affordable Care Act. And then it really drops down, considerably within the 2008-2013 timeframe, goes up as well from this time period on in 2014, which is when a major provision of the Affordable Care Act, and we had 30 something, now it's about 33 million Americans who have access to care. And so access to care meaning access to insurance. And so typically, if you have the ability to pay through insurance, you have access, you will use more care, or at least have the ability to use more care. And that's been somewhat consistent, certainly from 2014 on. But the purpose in really going over this is to demonstrate, when we talk about the cost of healthcare from a macro perspective, it certainly has, there are influences in terms of the care. I use the Affordable Care Act as an example. Certainly in terms of negative influences, I think about the pandemic and how many individuals have not accessed care irrespective of insurance status, irrespective of age as well. Perhaps the care wasn't available, or they just sought to forego the care because they were in lockdown, all kinds of different things. And there were other things related. So I wanted to start with that before, as a generalized, generalized, I'm not even sure if I can spell that correctly, perspective, but I'd like to go into a little specialty stuff as well. So the article that you have, two hotspotter articles, and I'm going to summarize a little bit here, even though you're going to read this article. Now, to be truthful, it's written by my favorite healthcare author, Atul Gawande, and you're going to read Atul Gawande's work quite often, certainly in the courses that I'm overseeing, but in this course specifically. This was written back in 2011 in the New Yorker, and it really told the story of Camden, New Jersey, and the Camden Coalition. And so Camden, New Jersey is known, has been known since the late 1960s, and certainly up until today, as one of the most impoverished, certainly certain zip codes in Camden, impoverished areas of the United States, and certainly the East Coast. Individuals are access healthcare in very direct ways without insurance. So the emergency department and the hospitals get full use. And a number of years ago, a physician who you'll read about, Jeff Brenner, and you actually hear from him when you listen to the NPR story as well, really became frustrated with the frequent readmissions to the various hospitals, especially the hospital that he was working in. And, he trained in this area as well. And so the question came to him and his team: how can we lower medical costs for these neediest patients who are extremely ill? And so, long story short, over a period of time, but you'll be fascinated, I think, to read about Dr. Brenner, and decided to drill down. And when they drilled down to find out who these individuals were, why the cost of care is so expensive, it came down to a group that they called super users. Super users are individuals who frequent healthcare consistently, often for the same services. So seeing what I'm doing here on the screen, which might be somewhat annoying to you, but they're back and forth. From an emergency department perspective, perhaps from even an inpatient perspective in hospitals, they're maybe known as frequent flyers, the same individuals that come in for the same diagnosis, same conditions. And it's a negative connotation. However, as Dr. Brenner and his team drilled down, they became aware of some very different parts of stories for these super users and this was really almost some of the first times that the healthcare world was introduced, at least the acute care world, to social determinants of health, which is a long-standing public health term. Social determinants of health: what determinants from a social perspective one's health, not so much healthcare, but one's health. Well, certainly housing, the adequacy of housing, one's socioeconomic status, and specifically your zip code. Zip code matters. Zip code, where you live, where you reside, influences your health. Urban, rural, access to services, a variety of different things. So looking at the social determinants of health, in addition to housing, socioeconomic status, zip code, education, crime within the zip code. They're all factors. Now, of course, there are clinical factors as well for individuals who have diabetes and congestive heart failure and COPD. And yet, it didn't deter their team from creating the Camden Coalition, as you'll read about. And the Camden Coalition is just a fascinating group, from my perspective, of entities that pool their resources to focus on the high users, the super users, the frequent flyers. And in addition to the clinical care, they're looking at other services as well. How can one's social determinants of health be improved, changed, altered, impacted? So rent, as an example, if one's rent is behind by 6 months and an eviction notice is coming up soon, that obviously influences health to different degrees. Might it be feasible that an attorney be brought in to assist individuals, we're talking about the same super users, who to manage a lease agreement? If heat is going to be turned off, could a prescription of heat be applied through an electrical or hydro company, and thus perhaps impacting one's arthritis or whatever the diagnosis is? The goal here was certainly to prevent readmission, but looking at a very different overall perspective. And so this was really the first time focusing on Camden and the coalition. When this article came out in 2011, I will tell you, it went like wildfire. The model was copied throughout the country, primarily in urban areas where there was a healthcare team who looked at not just the overall, focused on frequent flyers, super users, but also maybe a more broader social determinants of health aspect. So fast forward to 2020, where for the first time over, and this article here comes from the New England Journal of Medicine, authored by, that was interesting, authored by one of the foremost healthcare economists in the country, Amy Finkelstein. And it was really a randomized control trial, which is a gold standard of research that was done to examine the efficacy and the impact of the Camden Coalition. Interestingly, and this is, I've copied or screenshotted the discussion out of here, this trial, which looked at about 800 participants, really demonstrated that there was no significant effect in terms of decreased readmission rates when you compared a control group to an intervention group, and which really sort of refuted essentially the benefits of this Camden model. Now, part of it is, and so I'd like you to go through this. We're not dismissing it for sure, and also certainly listen to the NPR article, because Dr. Brenner is quoted in here. He's actually, unfortunately, a little deflated, but it is not deterring the team or the model from going forward. Part of it is the challenges associated with addressing super users and some of the social determinants of health are much more challenging than prescribing medication. So it's easier to prescribe medication, and the impact can be seen much more quickly. So it is much readmissions, which is where the highest cost of care, so we'll go back to the cost of care, is outlaid, is very challenging to impact, especially for individuals who not only have multiple chronic issues, but they're in a social situation or multiple social situations that is not easily impacted. So as an example, and I think this is mentioned, maybe not in the NPR story, but a few, some other associated articles. I go back to the living accommodations and heat. And it might be, there might be an ability to prescribe or to have an individual get a job to basically pay for heat, but if that job doesn't pan out after 2 years or after a year and they're back to the same situation, one's health either can decline or at least, well, it will continue to decline. And so it's not a magical situation to just alter one of these, one super user or super user social situation, because it can change very quickly based on the other factors associated with either social or medical issues. And so the actual story, which came out again just after the article came out, the NPR story, really doesn't prescribe abandoning the Camden Coalition, because it is certainly one of the more specialized and effective and innovative forms of care that does have an impact. Within reason and with serious limitations, but it doesn't have an impact on the cost. And so that model has really, as I said, been implemented around the country. And I dare you to find a part of the country, almost where all of you are, where there isn't a focus on, maybe they're not called super users, but certainly chronic illness, individuals with one or more chronic illness, to really almost segment them, to partition them away, and to focus on them in order to drill down on the cost, and or to really impact the cost. And so let me provide some overall thoughts as I sort of close off this content. Really, the impact for cost, there are many. There are really not as many factors. There's a handful of factors, as we saw earlier on in the lecture. But the notion of drilling down is key. Certainly, what we have, and the term super user might be a bit more friendly. We have individuals, at least today, who have multiple chronic illnesses. Those chronic illnesses can be managed. They can't be alleviated. They can be paused, as all of you know. But it's really where costs of care are the highest. And so for parts of our healthcare system to focus on this tends to make the most sense. At the same time, we know that individuals, irrespective of their health, are impacted by their social determinants of health. We all are. And so for parts of the country, for individuals who live in parts of the country where their zip code matters, they are overall going to be impacted, their health is going to be impacted in very different ways. And so these two things combined in terms of chronic illness and a focus on, let's say, social determinants of health and zip code have the potential to impact the cost of care more than anything else. And some of them are controllable and some of them are not. So let me stop right there. This really is a summary, hopefully a generalized and a specialized summary of a very complex topic, and we'll connect to it a little bit more in the course, and bring up some other issues, especially with super users, as we tackle some other topics. Okay, for now, I'll let you go. I'd like to say, please let me know if you have any questions. Of course, you can certainly email if there's something that isn't clear, or give me a call and we can talk about it. All right. Thanks very much, folks. Bye.